WHO recently put out on maintaining essential health services during COVID. And the second message for the webinar is to provide a brief summary of what is being reported to WHO with respect to effects that COVID may be having on HIV services. So next slide. So this is the guidance that was published on the 1st of June, maintaining essential health services, operational guidance for the COVID-19 context. And I provide a URL at the end of this presentation, but it's quite easy to find on the WHO website. This guidance provides practical action for reorganizing and safely maintaining access to high quality essential health services across a range of different diseases, but including also HIV, TB, and sexually transmitted infections and viral hepatitis. But it goes beyond that to also include recommendations and advice for vaccination, maternal child health, and so on. So it provides indications and key considerations about when to stop or modify and restart services depending on the status of the COVID-19 epidemic in a given setting. The first part of the guidance provides operational strategies for maintaining essential health services broadly, looking at issues like drug supply, community actions, and reorganization of hospitals and healthcare settings. And then the second part goes disease by disease to give specific recommendations. And then at the end, there's a list of indicators that could be used to monitor the ongoing availability of health service interventions and possible indicators for disruption. Next slide. So these are the basic principles. So timely access to emergency care needs to be maintained, adjust governance and coordination mechanisms, ensure infection prevention control. This document does not go through the range of recommendations for consideration for infection prevention and control for COVID-19. WHO has other guidance notes that provide more details for that. This is simply about reorganizing health services in light of COVID requirements and disruptions. So what can be delayed and what cannot? What can be relocated to other areas where less affected by COVID-19? And what are the particular needs of marginalized populations? And it gives some indications about health workers that may be able to be reassigned to other key tasks, the strengthening of monitoring of products, removing financial barriers to ensure that access to healthcare is free at the point of care, disseminating information in local languages so that any modifications to health service provision is understood by as broader number of the population as possible, and shifting delivery of some routine services to digital platforms to limit the number of people who are coming to present at health services for ancillary support. Next slide. So this is just to highlight that for HIV and also for TB, the modification of essential health services was partially guided by the outcomes of modelling work, which has suggested that for HIV, the single most important component of HIV programs is to keep a continuous supply of antiretroviral therapy, because modelling suggests that a 6-month total interruption of antiretroviral therapy could lead to up to 500,000 additional HIV-related deaths over a 4-year period and an increase in mother-to-child transmission. While for TB, a 25% reduction in TB detection could lead to a 13% increase in TB-related mortality. So using this modelling work allowed WHO to focus on the key components of HIV programs that need particular attention to ensure that they are able to continue during the COVID pandemic. Next slide. So I won't read out the information in this slide. This is simply to give you an idea of what you'll find if you go to the guideline document. The left-hand column is organising according to intervention type. The second column gives slightly more details of the specificities of each intervention. And then the third column on the right-hand side gives triggers for reinstatement of routine services and how and what actions can be taken to prepare for the reinstatement of return to normality. Next slide. We now have a few slides showing data from country surveys that WHO has been undertaking, looking at what we know about how services have been adapted and what possible problems they faced. So on this slide, we see that multi-month dispensing has already been widely adopted by a number of countries, and some countries have accelerated the policy of multi-month dispensing. So 3-monthly dispensing is by far the most common policy currently in place in a total of 143 countries surveyed. But there are almost 10% of countries have adopted 6-monthly dispensing, and only around 10% of countries have yet to adopt multi-month dispensing. So that's going well, but it's a double-edged sword because some countries have intensified multi-month dispensing, Malawi and Namibia, and that's gone well. But other countries have reduced the adoption of multi-month dispensing because of concerns about ARV drug supply. Indonesia and Botswana are examples. Next slide. So here we see that multi-month dispensing has also been adopted as a policy for other commodities: opioid substitution therapy, prophylactics, drugs for hepatitis C and hepatitis C have hepatitis B and hepatitis C have all also been allowed to be dispensed on a multi-month basis, usually for these medications every 3 months, but that also varies by country. Next slide. So what do we know about stockouts? We do have a number of countries that have reported stockouts of first-line medication, which of course is frustrating the policy of multi-month dispensing. But in the Africa region, 8 countries have reported stockouts. 5 countries have reported stockouts. The stockouts are indicated in the orange on this slide. So there are a number of stockout concerns, even for the basic, for TLD medication, that we need to be concerned about. And we are working hard with others to try and ensure that there are adequate supplies that can also support the adoption of the multi-month dispensing policy. Next slide. And this is to remind us that the stockouts and shortages that we have reported to us in WHO is not only for first-line antiretroviral therapy, but it's for a range of other essential commodities, including HIV testing, viral load monitoring, tools for male medical circumcision, and condom provision, as well as a number of other areas. So maintaining essential supply of commodities continues to be an area of concern that WHO is monitoring and working with partners to try to resolve. Next slide. And this is just to give a little bit of detail of some of the countries where we've seen stock challenges of particular commodities. lopinavir, ritonavir, quite importantly, 13 countries struggling to gain access to this medicine, atazanavir, and some pediatric medications, particularly in the Latin America region, less so in Africa, but some African countries also affected. Next slide. So I urge you all to take a look at the Essential Health Services guidance of WHO that's on the website, but the key actions I wanted to highlight are multi-month dispensing, and in particular giving favour to 6-monthly prescribing of ARVs, but also multi-month dispensing of related commodities, TB and prophylaxis for common co-infections, reduced frequency of viral load and lab testing, community distribution points and peer delivery to try and relieve the burden to essential health services where this can be possible and where it is possible to be done with physical distancing and other measures, suspending and reducing certain community-based activities such as, for example, mass male medical circumcision campaigns and mass community testing, emphasizing self-testing and sampling for HIV and STIs, using E&M health strategies to support disclosure, adherence, and related activities, and making plans for catch-up campaigns when the acute phase has been brought under control and services can resume, but the coverage of certain essential services has perhaps been temporarily reduced, and so catch-up campaigns can help to increase coverage. Next slide. So finally, this is the URL for the guidance, which is on the WHO website. If you just put maintaining essential health services into Google or similar search engine, you should be able to find the document quite easily. And on the right-hand side, this is our famous consolidated HIV guidelines that were published in 2016. And WHO is in the process of updating these guidelines, including new recommendations for HIV service delivery, not specific to COVID, but an update across a number of recommendations in general. And I would just like to highlight this because working with Sequin, we are planning to put out a brief survey to gain an understanding of values and preferences of some of the WHO recommendations. So we very much hope that you will be able to help us to get a better understanding of these recommendations and how they possibly need adapting in the future. So you should receive a link to this survey sometime in the near future, and I'd like to thank you in advance on behalf of WHO for your support. That's my presentation. Thank you very much. I'm happy to answer any questions. Over.
Thank you so much, Nathan. There is one question for you in the chat box, actually 2 questions from Anna in the chat box. So if you could answer in the chat box, that would be fantastic.
I will,
and
sure.
We are going to move on to the panel discussion. Again, a big round of applause for Dr. Ford, and the presentation was much appreciated. I should say that, as always, we will share slides and recordings on both the Sequin and IAS websites. Today, we are going to have a short panel discussion to get the perspective from our 3 colleagues who have been really spearheading this webinar series along with Laura and her team and others. And really, we asked them not to put together slides, but to give us their reflections on some questions. So next slide. We're going to ask them these 3 questions. And as a reminder, in about 12, 15 minutes, we're going to ask you your reflections on some questions by splitting into breakout rooms. So we'll hear your perspectives as well. But in the meantime, we are going to ask these questions. So Solange, I'm going to start with you, thinking about this first question. What are some of the most interesting innovations related to DSD that you've seen in response to COVID-19?
Hi, everyone. Thanks, Miriam. Great to be here. Just making sure you can hear me. Sorry.
Yes, carry on.
Okay, great. I think so ITBC, for those that aren't aware, we work globally and we work on HIV treatment access. And one of the major intersections with DSD that we have seen from the community perspective in terms of recipients of care are adherent support innovations. Really looking at like the creativity of community leaders to get around the restrictions, for example, of city crossing borders where people are under lockdown, got caught in the wrong city and therefore can't get their medicines, and being able to get medicines to people, I think has been critical and urgent, particularly for third line medicines, ARVs, and OST. I'm thinking about our partners in particular in Nepal and in India who have had to come up with ways to make sure that medicines get to people. I think that was quite interesting and innovative. I think when we were discussing, we were thinking about, okay, so just want to make sure that everyone kind of breaks out of the DSD is equal to multi-month dispensing, and really thinking about what other things are happening. And the next thing that strikes me is not necessarily an innovation, but really looking at COVID-19 in the context of DSD and the context of ARV supply, and the countries being forced to take a critical look at their supply chain, which, as Nathan has brought up and we know has been a nightmare from a recipient of care perspective for a long time regarding stockouts. Countries have now been able to do careful assessments and the analysis necessary for people living with HIV, but also in particular for specific groups, thinking particularly about children here, to guarantee or to look at what the supply chain is for 3 to 6 months of dispensing. And just lastly, thinking about digital use, it's come up, I think, the innovations and saying, well, you know, no, communities there's not enough penetration, there aren't any smartphones, it will not work, you can't do that, people must come in. And there were lots of issues with DSD in the start where we said, you know, nurses and other people are concerned at the clinic level that, you know, you must be seen in order to get good care, and we don't really trust the recipient of care to be able to handle, you know, knowing when they should come in. But now we can see that it works. And I think the question that comes to mind with regards to these innovations is, can they be sustained beyond the crisis? Is it just a COVID-19 thing? And I think I put that question to the groups as well when they break out. And just lastly, outside of DSD, the, you know, simple things like pop-up hand washing units in the rural areas that we've seen, really just showing that necessity is the mother of invention. You need clean water, and how do you get that to people who don't have running water in pipes? So those are some of the things I wanted to raise.
Great.
Thanks.
So in a way, the crisis has made space for community-led innovations and thinking outside the box. And we want not only to share those innovations, but to sustain them when they work. So great point. Peter, what, just to add on, not to repeat what Solange said, are there other DSD-related innovations that you've seen in response to COVID-19?
Thank you very much, Miriam, and good afternoon to everyone. So just to add to what Solange has said, I would rather want to talk about a country that has really innovated quickly during this COVID-19 era, and that is Sierra Leone. I mean, I was in Sierra Leone in January, just before the pandemic started, or rather just before it hit Africa. And I mean, Sierra Leone at that time had no DSD interventions at all. I mean, the country was beginning to discuss and to talk about what they wanted to do. They had not defined what their DSD models would be. I mean, there were no guidelines or operational guide on DSD. I mean, discussions were just beginning, you know. And then COVID happened, and I saw Sierra Leone quickly kind of adopted 3 multi-month dispensing, including 3 multi-month for newly initiated patients, so long as they are asymptomatic. And I mean, I thought that was very interesting how quickly they were able to adopt DSD. Even still, they don't have guidelines, they don't have operational guide, but they have managed to, kind of organize their net partners, donors and implementing partners, and the network of people living with HIV to kind of quickly adapt some DSD models and take them to scale. And interestingly, also adapting community-based models, including, during the lockdown, home-based deliveries. And I thought that was very, interesting that they were able to quickly do that, working in partnership with other stakeholders in the country, using a multi-sectoral approach that, some countries have kind of like left behind, and they were able to quickly, rally and make sure that, no patient was left behind. And I thought that was very interesting, actually.
Great, thank you. So yeah, I sort of nimble and multi-sectoral response from Sierra Leone. Anna, what about you? I know it's always hardest to answer last. Any additions, any other innovations that you want to highlight?
Yeah, so I think overall we've seen that the HIV community has been able to be very adaptable and flexible at a really quick pace in order to ensure uninterrupted supply. And I want to kind of echo and almost group together some of the things that both Peter and Solange said, and that we've seen through this webinar series, in fact, examples from all the countries in terms of innovations that have happened. So 3 big ones for me have been this push towards out-of-facility distribution. So we saw examples like in Uganda with accelerating CDDPs, and also adapting existing models like the community adherence groups and adherence clubs to be physically distanced, as has happened in Sierra Leone and in Kenya. And then across the board, we've seen a lot of push to earlier access to differentiated service delivery. So as Solange mentioned, for children and adolescents, as Peter mentioned, post-initiation, and we see from PEPFAR and others an interest in ensuring longer drug supply, even for people with advanced HIV disease, acknowledging that they may not be able to access clinics as easily during this period. And then third, we've seen a kind of pause in some way, or at least a reduction and a reconsideration around what is essential HIV services during this time. We've seen countries expand the duration of scripts, so not just refills, but the prescription scripts, like has happened in South Africa, reduced frequency of clinical visits, and less intensive viral load monitoring, again, to support people in terms of not having to come to the clinic so often. So just to kind of applaud all of the countries that have shared on these webinars, all of the adaptations that they've made during this time. Great.
So I don't want to shorten our breakout session. So in the interest of time, I'm going to ask people to, the 3 of you, to respond to sort of a combination of our next 2 questions. So we'll do one more round. So if you want to say what keeps you up at night, you can say that too. But then also, what are the priorities moving forward, and how is your organization responding? So Solange, over to you.
Oh dear, trying to combine those 2. Look, what is it? I don't know how many, 4 years back, WHO recommended DSD, right? And I remember my worry at the start was, are we going to be able to balance both things? When you think about success for DSD very broadly, is it this sort of quote unquote client-centered, responding to the needs of people, or is it really about gaining the efficiencies within the system? And the answer that everyone gave me was that it's both. And I still do believe that one will always win. And I think at the beginning, it was at best, slow, very policy driven. We need to prove everything. How fast is fast track? Let's go measure. But now we have a new context that shows that it can be done, right? Again, back to this necessity being the mother of invention. We were able to change the flow of people. We're better at managing people in clinics. We're saying, stand here, leave here, do this, do that. So then what was the real barrier? Maybe it has to do more with political will and the fact that the threat is now immediate. If you don't do this, there's actual repercussions for people's lives, like very immediately. And I worry about these things, DSD being for health, not just for HIV and treatment, but for prevention, TB, OST, and for everyone, right? We've talked about it for key populations, people using drugs, people with advanced disease, for children. And I think there's so many unknowns there. And what keeps me up at night is knowing that this could have been done before. So I'm not in a rush to get back to the normal, to what was before, because I think what was before was piss poor and really needs to be improved. So I really believe that we really need to think about how the innovations that we've gotten to now and the quick policy changes and the adaptations and the flexibility, and all of a sudden the system that was so weak and fragile and heavy and bureaucratic and slow to move is now nimble and flexible and responsive and doing things that couldn't have done before. And I think that has to do with the political ramifications. So I really worry about that. I worry about misinformation and communities being able to access timely and accurate information as it relates to COVID-19 and HIV and everything else. And then my last worry, because I have lots of long list of worries, is really about the social safety net for communities, right? I think the focus on households versus the focus on governments as the sort of the unit level of intervention is where we need to focus. So communities are the ones that are actually being able to track. Contact tracing, if you think of the core of the work of these pandemics, has to do with investing in the household and in communities. And they're not getting the support necessary to do that, to do community monitoring, to do the contact tracing, to be able to go out there. They have been without transportation, without PPE, without food, without, many of the basic things. And that's where I think the whole holistic response, sorry, I've gone way off from DSD now, but those are the things that keep me up at night. Yeah, okay. I'll stop there.
Thank you. Excellent points. Peter?
Yeah, thank you. I would just basically talk about, like priorities of moving forward. Solange has, discussed a lot of what keeps all of us, up at night. And for me, I think that COVID has really taught us a lot of lessons. We've learned that, we can really, like Solange was saying, do these things, take people outside the facility. And we need to do that because clearly, if and the next pandemic hits us and we still have so many patients coming to the facility every day, we will not be able to cope. So I think that we need to continue to focus on scaling up DSD for both people who are doing well on treatment and also other populations such as pregnant and breastfeeding women, children, adolescents. As we see, with COVID, despite the resistance countries had earlier, especially for pregnant and breastfeeding.
We've lost Peter's audio. So he was highlighting the importance of expanding DSD to not only adults who are doing well on ART, but to diverse populations, as Solange says. And then I think from the Sequin perspective, other priorities include documenting, so making sure that the models that we think work are in fact working. So making sure that we harness the routine monitoring and evaluation, the qualitative feedback from recipients of care and communities, as well as implementation science, where it doesn't slow down service delivery, but really enables us to come back and say, look, these innovations, this nimbleness on the part of ministries and communities, and the whole sort of intersectoral community, they worked, and here's how we know they work. So that may help us to continue them after the emergency. In terms of what Sequin is doing in response, so we are going to continue to try to facilitate exchange of best practices with the communities of practice that are continuing to meet, with our newsletter and WhatsApp groups. We are also going to have a virtual workshop on advanced HIV disease that you'll hear more about, but in the next few months. And we are going to expand the number of countries. So we have gotten the green light from our advisory board, even in this virtual context, to add new countries to the network. So you'll hear more about that in the next month. And then Anna, could you tell us what the next steps are, or what your thoughts are about this? And at the same time, Laura, can you go to the next slide? Because I think this is, go to Anna's slide. Perfect. Okay, Anna, over to you.
Great, thanks a lot, Miriam. So just to say briefly in terms of what we are doing, I think we really want to make sure that we also use this opportunity to support and leverage DSD for family planning. That's an area that we'd like to build on more later in 2020, as well as for PrEP. We've seen some of the same kind of benefits in terms of innovation around differentiated ART delivery happening in the PrEP space, and that's really exciting. And then in addition to support all the community work, we want to make sure that we remove some of these barriers that exist to implementing community-based models, such as the lengthy accreditation for community pickup points, as well as what both Sequin and ITBC were saying in terms of not backtracking on where we've seen success. So in addition to what keeps me up at night regarding AIDS 2020 virtual and pre-records, we do have some things that keep us up around whether or not the policies we've all mentioned are happening on the ground, as well as whether or not the people who were in group models or used to get peer adherence support are getting that support during these times of lockdown and during these times when there is so many physical distancing requirements in place. I'm going to really briefly take you through just a short deck here around AIDS 2020 virtual, because I want to highlight to those of you in this DSD space all of the great science that is forthcoming. So you can go ahead and hit next, Laura, and next again. So we've put together this DSD roadmap, and it's available on the home page of the DSD website. And I just really wanted to let all of you know that for those of you who are registered, the vast majority of the content for AIDS 2020 virtual is available from the 4th of July. So many of us are engaged at the moment in pre-recordings for satellites, pre-recordings for symposia, pre-recordings for abstract-driven sessions. So don't wait until Monday the 6th. Join us from the afternoon if you're in a time zone similar to mine on the 4th of July when a lot of the content goes online, because this year it's really live on demand, so much more like Netflix, and this is just something to keep in mind. So next slide. We put together this roadmap, and that gives us the insight into all of the science that's been submitted to the conference, which is just amazing. So it looks like the document on the left-hand side is just a PDF. And one thing I just screenshotted in the bottom right-hand corner there is just an excerpt of the number of posters. I think the roadmap's 9 pages long because of the number of posters, just so you guys all know. And on the next slide, if you'll advance, you'll see that there's a number of sessions that have some really amazing DSD content. So there's 4 satellites listed there. Some of these people will be familiar to you that are on these satellites. There's 2 late breaker abstract sessions that have DSD science, which is really hot off the press. There's a bridging and symposia session, 2 oral abstract sessions, and 2 poster discussion sessions. And so again, just to highlight that many of these will be available from the 4th of July as they are on demand, meaning that you can access them anytime. Next slide. And then in addition to all of those, I think we have over 60 or so e-posters that feature some really interesting science from many of you on the call, from many of the countries where you work, from many active members of the Sequin network. And so we really just invite you to be sure that you utilize the conference to engage in all the ways and see all of the science. That's all from me. Thanks, Miriam.
Great. Thank you very much to the panel. If you have questions for the panel, you can continue to type them into the chat box. But now we are going to go into breakout rooms. So what is going to happen when I turn over to Laura is that you will see a pop-up on your screen that will invite you to a breakout. You should click join breakout room. And then you may actually see this right now. Then you will be in a Zoom session with a smaller number of people, probably about 10 people. You should have a facilitator in your room. If you want to leave to return to the main room, you can click leave, but then you'll have to wait for everyone else to get back. If you need French translation, there will be a specific room for the French translation, and you can just let your facilitator know there'll be that you want to move to that room. Next slide. So what are you going to do in these breakout rooms? We are going to give you about 10 minutes, and we would like you to discuss amongst yourselves two very broad questions. One is, what needs to happen to ensure good health outcomes for people living with HIV in the time of COVID-19? And the second is, how can the Sequin Learning Network help? So it's not a lot of time, but so we'll want you to start by choosing a rapporteur, because we are going to reconvene after about 10 minutes, and we'll call on, depending on how much time we have, some of the rapporteurs to share the outcomes. We'll ask all of the rapporteurs to share a quick summary in the chat box. Again, the people are listed. If you look at their names, they'll have like name and then dash facilitator. So you'll know that there's a facilitator in your room. You can always ask for help if there's any questions or problems. So I'm going to ask everybody to click join breakout room now and meet your breakout partners. Hi everyone, welcome back to the main room. We're going to wait until all the other groups have joined to reconvene or to restart. I know that was a very short discussion. Okay, thank you, everybody. I know that was a very short discussion. Sorry, it was a little shorter than I was anticipating. So not everyone got a chance to talk. But I did want to ask the various groups to just reflect a little bit on that discussion. So there were 5 rooms. So I think the first room, Frank, you were the facilitator, was the room 1. Did you have a rapporteur?
Yes, Miriam. Jean-Jacques is our rapporteur. Jean-Jacques Mbea.
Okay, Jean-Jacques.
Okay. As my group was a French group, I will speak in French.
Yes,
so
we will.
Okay. Pour la première question, dans le contexte du Covid, que pensez-vous qu'on devrait faire pour garantir un bon devenir des PEVIH? Le groupe a proposé qu'il fallait renforcer l'information essentielle sur le Covid au niveau des PEVIH. Donc, les sensibiliser les PEVIH.
Raise awareness for people living with HIV on prevention measures for COVID. The second aspect was to guarantee access to medications for HIV patients by ensuring a good supply of treatment, ART treatments at the healthcare facilities, and avoiding stockouts. That's for the first question. And then in the group, we were focused on the updates being communicated on COVID and sharing country experiences. That's what the group gave in terms of information. Thank you for your attention.
Thank you very much, and thank you to the interpreters. Group 2, I believe Katie Godfrey is the rapporteur. Katie? Katie, you're still on mute.
Unmute. Okay. Yeah. Sorry. Sorry. Thank you for that. So our group was very focused on continuing to provide services in a safe and in a safe way. There's a discussion of lay providers providing services, but and with appropriate PPE to do it safely. I think another comment had to do with the fact that it's not just about providing ART, but it's also the lab monitoring. Measuring success is really important. And there was discussion of integrating other kinds of services in with the ART services, both the community and TB care, and including collecting samples during ART distribution, again, in the setting of safety. I think that one of the, I think that promoting those services was, I think, the kind of underlying theme of what could be, what Sequin could do to facilitate that. We also discussed the importance of integrating other kinds of medical conditions in with the community care, but we didn't really get to have a full discussion of that. Over. I think that's it.
Yep. Thank you, Katie. We did have a very telegraphic conversation, so that was an excellent summary. Martin, who is the facilitator or the rapporteur, sorry, for group 3?
Josen from Uganda.
Excellent. Josen, please go ahead.
We briefly discussed this. Question 1, what needs to be done is to demystify COVID-19 and support the people living with HIV to access the services they need, even when they are at the facility. Because currently, because of the kind of stigma put around COVID-19, some of the people living with HIV are failing to access these services due to fear of contracting COVID-19. And then we need to continue letting the recipients of care know that the facilities are still open to provide a wide range of services in ways that prevent infection. And then we need to strengthen the supply chain systems to ensure continued supply of whatsoever commodities are needed. We don't want to have interruptions. And the other is to strengthen follow-up of recipients of care. And this can be through remotely telephone calls and SMS reminders. We need to strengthen documentation of services provided, even when they are not provided at the parent facility, but also strengthen infection prevention and control. We didn't have time to discuss question 2, but personally, this is what I would say as part of the group. One is CIQUI needs to continue supporting these virtual meetings, holding the virtual meetings till a time when the physical meetings can happen, but also continuing to facilitate the knowledge exchange between the member countries. Thank you. That's what Group 3 had.
Excellent. Shared. Thank you. And I believe that Wame Jallow is the rapporteur for Group 4.
Hi, good afternoon, everyone. I think a lot of the points have been raised already, but just to highlight just 2 more points. In our group, we talked about the need to really reinforce the innovation that is bringing the ARTs to the community level. And this is particularly visible in cases where, or in countries where less people are coming to the clinics and there's a greater effect towards retention and care accordingly. The next point that was raised was around losing the intensity of care. And this is particularly looking at certain populations that were getting reinforced support at health facility level. So adolescents as an example, there is a loss of opportunity to sort of intensify the adherence support, right dosing according to weight, etc. And we just need to make sure that we can pay attention to those specific groups, and also strengthening the M&E system to ensure that routine viral load testing for people is still being done. Thank you.
Fantastic, thank you. And I believe Thais is the moderator for the rapporteur for Group 5.
Yes, hello, can you hear me?
Yes, thank you.
Thank you. So it was a really brief discussion, but during the discussion, we discussed the first question we were able to address. So one of the things is regarding supply chain. So ensuring access to ARV drugs are critical. And we also have an experience from Uganda. So one of the things that we acknowledge together also is regarding the vulnerabilities among people living with HIV, especially children, because food issues, transportation, nutrition, all of the impact among this the subpopulation regarding the lockdown, and also engaging the recipients of care in support and design services to them. And again, we were not able to have time to discuss the question too.
That is fine, that is fine. Thank you, everybody. I think when we do this again, we'll give much more time for these discussions, but even this sort of very short telegraphic exchange has been enormously helpful. Laura, could you advance to the next slide, which is really just our sorry, next slide after that. Yes, our next steps. So the one before that. The next slide. Perfect. So we are going to take a pause with this weekly webinar series because there's so much happening in July. So as Anna highlighted, starting on July 4th, there's just going to be the Netflix of AIDS 2020 information. There's going to be on-demand, lots of great rich content about DSD and other things. So we encourage people to do that. We are, as I mentioned, going to have a virtual advanced HIV disease workshop in late July. So stay tuned for updates about that. We are going to reconvene in either August or September, this webinar series. So let us know your preferences and check the Sequin website and newsletters for details. Next slide. So again, as always, the slides and recordings are posted to the website, as well as guidelines, protocols, case studies. If you have things to share, even while we're on our hiatus, please do. And I did want to take our last 30 seconds to just give a huge thank you to the team that's been organizing these webinars. So I already thanked Peter, Solange, and Anna, but the sort of power behind the throne here is actually Laura, Pepile, Leocadi, Christine, and the whole team. So I really just wanted to end with a big round of applause for them. And to thank all of you for your participation, and we hope to see you online soon. Thanks, everybody.
Thank you.
Thank you.
Bye, everyone.
Thank you, everyone. Bye.